Okay, I think we have about a quorum. Are you all right if we get started, Elizabeth?
Sure. Yeah.
All right. Well, we'll go ahead and get started. Welcome everyone to Geriatric Medicine Grand Rounds. I'm glad that you are joining us today. Our speaker today is familiar to most of you, but I'll introduce her for those of you who don't know her and just tell you a little bit more about what she's been up to. I'm sure some of the fellows might not know all of the wonderful things that Dr. Phelan does, but she is a professor of medicine in our division and is also an adjunct professor of health services here at the University of Washington. She's also an affiliate investigator at Kaiser Permanente. She, practices in many settings, but most of you are familiar with the fact that she's the founding medical director of our fall prevention clinic here at Harborview, which started in 2005 and has been continuously running since then. She has been well funded on many grants, has done a lot of research to improve the care of older adults, focusing on geriatric syndromes, including falls, and is a nationally, if not internationally known expert in fall prevention. And for those of you who have used the study toolkit that the CDC uses to prevent and manage fall risk, she was involved in the development of that. So anyway, it is just with great pleasure that I introduce Dr. Phelan today to talk about fall risk. Who better to speak about it? So thank you.
Thanks, Kate. This is a talk that I gave a short version of back in December last year to the CDC. They have a periodic meeting gathering fall prevention experts and look at current data and out of CDC, but also out of people who are funded by the CDC. And this was a topic that they were interested in. And so I developed it as a new talk. A lot of it's going to be based on experience, interestingly, but I tried to pull data where it was available to give you a flavor for the key themes here. So just disclosures, I have a couple of grants focusing on reducing use of high-risk medications in older adults. One that is from the CDC focuses on, I probably remember hearing me present on it a couple of times before. We call it Stop Falls for short, and it focuses on reducing CNS active medications with the primary outcome of medically treated falls. We're in analysis phase of that trial right now, and it targets cognitively intact older adults. The other funding source to disclose is I have pilot award funding from the NIA through a subaward from Brown with colleagues Shelley Gray and Ben Balderson to look at deprescribing essentially with older adults with dementia, people who were excluded from our main trial. We're trying to extend the intervention to the people with dementia who weren't part of the original trial. So objectives, I will define what is meant by therapeutic switching, although you can probably guess what that is because many of you are clinicians. I'll look at what are common switches that I've seen in practice, and also, as I mentioned, the little bit of literature on switching that exists, I'll share with you. I'll talk about what switches are preferable, but typically I don't see happening, and build that out a little bit to talk about switches broadly. But first, let's just look at this framework. This is becoming common parlance in geriatric circles. And as you can see from this image of the 4Ms framework, medications are one of the 4 core domains of age-friendly care. So we really need to be paying special attention to medications as we care for older adults. And really, one of the key things here is to help older adults achieve what matters to them and avoid unnecessary harms. And often this involves stopping medications, especially ones that are considered potentially inappropriate. And this is particularly important for older adults who are frail, cognitively impaired, et cetera. Oftentimes, however, in place of these high-risk medications, as I'm focusing on today, and as you'll see, another medication might be substituted to manage the underlying symptoms. And I'm going to be, again, focusing on drugs in the context of falls and fall injuries. So it's not to say that there aren't other adverse effects of these drugs, but I won't be talking about those specifically today. So this slide is a summary of the updated, probably soon to be presented 2023. This was the draft of the beers from 2022, November 2022, summarizing the data around and the recommendations around medications to avoid in older adults with a history of falls and fractures. This is not much change from the 2019 beers, just to note. In the 2019 beers, opioids appeared for the first time. The other classes of medicines have been really known through primarily epidemiologic studies for quite some time to be associated with falls and fall injuries. So you can see the rationale and some of the specific recommendations that have come out around certain classes of medications, particularly in the antidepressant realm over the years, trying to parse out which of these might be safer, which might be less safe. And it does look like they're calling out that SNRIs may confer higher fall risk compared to SSRIs in this latest version of the beers. They note in the text that if any one of these drugs needs to be used, then trying to reduce the guideline recommendation is to try to reduce use of other drugs, number one, and number two, to implement other strategies to reduce fall risk. So I'm sure Jenny has seen patients like this. I just saw a patient this week who is on multiple medications for anxiety and depression. And so we are doing everything we can to reduce any medications that are for symptom control, and also, as the guidelines recommend, trying to do other things, everything that we can do around other fall risk factors. It's also important to note that, and that it's mentioned in the guideline, that short-acting benzos are no safer than long-acting, and other data suggests that intermittent use, new use, are both as risky as chronic use. So what do we know about use in the community and older adults living in the community? It's interesting, there is less data than you might think, especially longitudinal data. This was a study that, and I tried to focus on looking for as current as possible, of course, data on prevalence of use for this presentation. This was actually a cross-sectional study of a single year of data for which use of these medications was able to be examined. It comes from the Medical Expenditure Panel Survey, or the MEPS, from 2016. That was the most recent year where data from the MEPS were available. And this is a nationally representative sample of the US population. And they wanted to quantify use, any use and long-term use patterns of psychoactive medication among older adults living in the community. So their sample included adults aged 60 to 85, and again from the 2016 survey. And they defined long-term use in the way that most or many other studies do, which is at least 3 or more prescription fills over the course of that year. So right about a third of older adults, all comers in the survey, were taking at least one psychoactive medication, and about a quarter of them were using, met the definition of long-term use. You can see that some differences by race and gender and socioeconomic status here. And interestingly, in this sample, these 5 drugs were the most commonly prescribed. Excuse me. And counterintuitive to what you might imagine, psychoactive medication use in people who live in the community who have a dementia diagnosis actually are taking more of these so-called psychoactive or CNS active medications. So this was Medicare beneficiaries with dementia in fee-for-service Medicare, who also had Part D, which is the Medicare or the medication coverage. Nearly 1 million people with a mean age of 82, and you can see prevalence of the various classes of these CNS or psychoactive medications. And as scary as it might seem, use of any one of these classes of medications in this sample of people with dementia was over, almost three quarters of that sample. This is such a problem that it's gotten quite a bit of press. If you look in, online, you can find articles such as this from the Washington Post. Also, I'm sure many of you have seen articles to this effect in the New York Times and other nationally syndicated newspapers. This is a recognized issue and one that has rightfully been given some public attention. Focusing on what do older adults know and want? So there have been a number of survey studies now that have been conducted that show that most older adults really do want to reduce the number of medications they take, and that they really value avoiding the adverse effects associated with medications. And along with that is low awareness of the risks of many of the medications that they take. And interestingly, one study that I was just reviewing by Donovan Most, who's done a lot of work in describing the problem of use of psychoactive medications, actually found that provider factors were accounted for most of the lack of discontinuation, not patient factors. So I think it's important, it's an important message for us to bear in mind that there's as you're probably familiar with this term, prescribing inertia, that exists in practice for various reasons. And I think knowing that older adults are receptive to having these conversations can really help us to feel encouraged to bring up this topic with them. So that's a bit of background, setting the stage. And so again, therapeutic switching is something that a provider does. So we're looking today at practice behavior. And so what do we mean by therapeutic switching? This is the definition. It's replacing with the prescriber's approval and involvement one prescription medication that was originally prescribed for a patient with an alternative medication. This could be a substitution either within the same class or from another class that has assumed therapeutic equivalence. What's important to note about this definition is that there is no mention of safety. The emphasis is really on the effectiveness of a medication. So, and as we all know, and as I've already mentioned, really thinking about safety rises to the top in terms of how we think about medications that we prescribe with people who are in the older age groups. And again, especially people who have already fallen or are at increased risk of falls, with people with dementia being one of those groups. So, you know, I guess one of the things to mention here is that intentions are probably good on the part of the provider, right? They're concerned about the person still having a symptom that's bothersome. And so this is not to say that there isn't a desire to actually try to do something that's of benefit. But the key issue is we all need to understand what are the risks of these treatments that are reached for as alternatives. So now I'll start to talk with you about the switches that I've seen in practice. Before that, though, the little bit of literature that has looked at switches, I'll share with you. So there's a couple of studies, and I'll show this first one, which is the Empower study, which was published back in 2014. It was a study that delivered direct to patient education and focused in this trial on the class of medications, only benzodiazepines. And of the 40 people who were in the intervention arm who discontinued successfully off of a benzo, about a little bit over 10%, so 13% were switched to, excuse me, were switched to one of these other classes of medications. So interesting to see the choices here. I think as geriatricians, we probably are disavowed of using paroxetine due to its strong anticholinergic properties within the class of SSRIs. We would probably choose something different. But at any rate, these were patients in primary care practice in Canada where the study was conducted. And you can see the switches that happened in that trial. This study built off the Empower trial and used the same idea of a educational intervention with direct to patient education, but combined it with information and decision support sent by pharmacists to the participants' primary care provider. And here you can see that, again, just focusing on sedative hypnotics, 58 participants who discontinued were switched, of 58 rather, who were switched, again, almost 10%, so 9% were switched to another, actually, in all instances, a different sedative hypnotic. So you can see switching, as I mentioned, within class. And also, it's hard to know what the person originally started off on, if they were on a benzo first, or because this study looked at both benzos and Z drugs. But at any rate, there appears to be a lot of within class switching, which is striking. So looking at the switches that I've seen most commonly in practice, I've shown those here. So what I'm going to do is in the next few minutes walk you through the data on these medications that are the ones that, again, providers are reaching for management of the symptoms that they're trying to mitigate with their patients in avoiding benzos and Z drugs. So Trazodone, I've tried where there is data on community dwelling older adults to present. I'll present that data, pull that, we'll present it. Not focused so much on the nursing home environment, but I think nursing homes are a good proxy for older adults with dementia and also and/or frailty. So one of the more recent studies looked at, and interestingly, was with the nursing home population, comparing use of the risks of use of low-dose trazodones to benzos, and found that essentially there was no difference between the rate of fall-related hospitalizations with exposure to trazodone versus benzos. Another study from a different country looked at psychoactive medication use and followed up for ascertainment of falls through nurses' notes in the patient records in this environment in Belgium, and found that antidepressant use confirmed that, as had been shown in other studies, that antidepressant use of any class increased falls. But interestingly found that those who were on trazodone, either by itself or along with another antidepressant, fell more than those who were not on trazodone. And that was a statistically significant finding. As I recall, this study also looked at low dose use. So we're talking, not doses that would be typically used for depression, but doses that would be similar to what we would think about for sleep. So something like 50 milligrams. And in the one study that I found looking at community dwelling older adults, this was a study, again, not done here, but in Canada. This study looked at a group of people who had a hip fracture. So again, a group that hip fracture being a proxy for osteoporosis and a classic type of injury from a fall, so tells you that this is a sample that's most likely a group of fallers. Interestingly, after discharge to home from a rehab stay, new prescription of an antidepressant occurred in almost 10% of the sample. And trazodone was the most frequent medication prescribed among all the different classes. And you can see the correlates for use for prescription of antidepressants here. So again, things you want to worry about. Baseline use of another psychoactive medication, for example, and dementia diagnosis. So I'm not going to focus a lot on co-prescribing, but that's certainly also a phenomenon. Mirtazapine, again, a drug that is often used for sleep, sometimes in people already with depression, but sometimes, again, a drug that a provider will reach for, thinking that it may be safer. And the theme here, as you're probably already starting to glean, is that this medication increased the risk of falls and fracture. This was a general practice population, a large sample of older adults. Hydroxyzine has really come into favor in the general medical practice world, and see a lot of people getting that these days. When somebody we see people who are under the age of 65, so the so-called near elders age group. A lot of them are on this for anxiety. This was a systematic review of a small number of observational studies that showed an increased risk of injurious falls with the first generation antihistamines. And then another study looking at anticholinergics from our backyard and the Women's Health Initiative, led by Zachary Markham, and Shelley Gray was a collaborator. This is, again, a large study, Women's Health Initiative, so women only, and looked at anticholinergics of all classes. And the most common use was, again, antihistamines. And there was an increased likelihood of recurrent falls, and the odds of recurrent falls increased if there were multiple anticholinergics used. And I bring this up because the other finding that I wanted to make sure people are aware of is there is a lot of self-prescribing. So even though I'm really focusing on switches made by providers of prescription medications, I would be remiss if I didn't mention that older adults often go to a pharmacy and get Tylenol PM, Advil PM, or just simply plain Benadryl. I saw a gentleman in clinic this past week who was taking 2 Benadryl at night along with two Advil, so treating for pain and insomnia. And his partner said, you know, I don't think it helps him at all because he still gets up throughout the night to go to the bathroom. And so habits may die hard. He was somebody who was very receptive to actually stopping that medication when we spoke about it. But again, just as a reminder, we do need to ask about over-the-counter anticholinergic agents as well as look at prescribing of those first-generation antihistamines, which are very strongly anticholinergic. So that's those are the substitutions around sedative hypnotics, and now I'll turn to opioids. And again, these are 2 classes of medications that are probably because of their physical dependence and in some cases psychological dependence are if not the most challenging to deprescribe, and also for providers trying to find a safer alternative, knowing that guidelines recommend avoidance of these classes of medications. So awareness of the need to discontinue these 2 classes of medications is high. And I think that, again, you'll see that we can help through our practice in promulgating these findings that I'm sharing with you today amongst colleagues about some of these other drugs that there may be less awareness of risk around in the provider community. So let's look at the common therapeutic switches for opioids that I see in practice. I'm going to go through each of these. So tramadol, you know, this is you all know this has potent opioid properties, and it's often used for knee pain, guideline recommended in the past for that purpose. And this study, led by Musich et al., looked at a very large sample of Medicare enrollees and diagnosis of OA and use of tramadol, actually short-term use, but for at least 31 days, and examines the association of use with a variety of safety events as shown here. So ED visits, falls, fractures, et cetera. And then focusing again today on the risk specific to falls and hip fracture. New use was associated with an increased risk of falls or hip fracture, as was continued use. Gabapentin, one that it is in, I would say, ubiquitous use in attempts to control pain, and not necessarily for neuropathic pain either. This off-label use, has really not been, it's actually been marketed for these off-label uses by the manufacturers without a lot of data. And there's essentially recent data that has shown that gabapentin is associated with dizziness and sedation, falls, fractures, and overdose, especially if it's combined with other drugs that are CNS active. There is an interesting article for people who might want to read further about the off-label use and the marketing of this drug by Peckham et al., published in 2018. Anybody who's interested in that, I have that article and I can share that with you. So in essence, gabapentin is probably not as benign as we might think. This is a study looking at duloxetine. Again, another drug that's recommended for pain, musculoskeletal pain, knee and back pain, and neuropathic pain for people with diabetes, for example. We typically see that dosed for pain in the same range as what's used for depression. And this study was a systematic review of adverse events associated with antidepressants, in which duloxetine was found to have an increased risk of adverse events overall, and again, specifically for risk of falls compared to placebo. We, as geriatricians, probably avoid using tricyclics as a class, but I definitely do see this in referrals to our clinic, to the Falls Clinic. It's still used quite heavily in certain populations who have neuropathic pain. So people who, for example, have HIV associated peripheral neuropathy. And in this study by colleagues from the CDC, Yara Haddad, Gwen Bergen, and others, using Medicare current beneficiary data, they examined self-reported falls and medication use according to class, and found that a significantly higher percent of people who were taking a tricyclic reported a fall compared to people who were not taking that class of antidepressant medication. Another study looking at this medication, again, in community dwelling older adults, showed that this medication has been associated with hospitalizations for falls and fractures. So quite large odds ratio there. And also demonstrated that the longer the prescription duration, the higher the risk. And our friends, the skeletal muscle relaxants, I see mainly methocarbamol, but certainly other skeletal muscle relaxers as well, used in older adults. This is a study from VA, using VA data, again, a new user study, like some of these other ones that I've shown you, using a retrospective cohort design, and looked at care for receipt of either emergency or hospital care for falls and fracture after a prescription for a skeletal muscle relaxant, and found a higher increased risk of that outcome for people who were taking methocarbamol. And an older study now, but using nationally representative data this is a nationally representative sample of survey of all older adults who are non-institutionalized in the US. And it gathers data from primary care visits. And they looked for people who had an injury code as well as a prescription for skeletal muscle relaxants. And again, found that this was really kind of echoing the results of the prevalence data that I showed you earlier, in terms of who was more likely to get prescribed some of these medications, building out, though, looking at rurality and visit frequency. So some other correlates that build off the correlates that I showed you earlier. Interestingly, did find that non-white race here, counter to the prevalence data that I showed you from the US, the MEPS survey, non-white race was associated with a higher likelihood of getting a prescription for skeletal muscle relaxants in this study. But more visits also, and again, rurality was found to be more increase the likelihood of prescription for one of these medications. So turning now to switches that I don't see too commonly, but we counsel patients on in clinic. There's one switch, and again, I'm going to take liberty with the term switch at this point. As I talk through this second part of the presentation, I'm going to just focus on these drugs. We have what seems to be a safer alternative to medications that are typically used for bladder spasm, overactive bladder, listed here, oxybutynin and trospium. Still see a fair amount of those drugs used in practice. Mirabegron, I think we're familiar with it as geriatrics providers, but you know, I have patients who have been to urology that I share with urology, and they're still getting oxybutynin as opposed to this agent. So again, something that we can, I think, try to look for and recommend for people, as long as this medication would seem to not have undue risks, for example, with the risks that go along with it, especially people who have uncontrolled hypertension, but also the other side effects that it might increase the risk of. Cost is also a consideration, but I think the cost of this medication will come down. But it does in some instances preclude its prescription. And I think that's an important health equity issue just to raise. So the liberty now that I'm taking with the switching is to extend beyond medications to ask, what about no medication at all? So in the trial that I mentioned, the Stop Falls trial that we're doing, we, with the expertise of Ben Balderson, who's a psychologist who sees patients in his clinical work regularly for managing symptoms that these drugs are used for through psychotherapy methods, and is really an expert on non-pharmacologic approaches to symptom control. He worked to develop these handouts that our trial participants are getting on approaches to managing the symptoms for which these medications are typically prescribed. So there is you know, good data about that I'll walk through just an overview of next that arises from years of research on how to manage these symptoms in ways other than through medications. So for pain, insomnia, anxiety, the guideline recommended therapies are listed here. So, and you can see, I think, kind of there's a cross-cutting benefit to some of these modalities, specifically Tai Chi and cognitive behavioral therapy. Trying to help patients find these programs and also their availability is an issue that we have to contend with, and certainly it takes longer for us to prescribe exercise or identify a resource for cognitive behavioral therapy. And maybe in the discussion, if we have time, we can talk about what are some local resources. But I did want to point everybody to the NCOA, which has cataloged evidence-based programs that are arthritis appropriate. So AA, EBPs, if you read the literature, they're so called. It's a locator, so you can search by program at this website. And, you know, arthritis, this slide highlights that arthritis is one of the top 10 most common chronic conditions. So we're really, when we're talking about chronic pain, we're probably talking about an arthritic pain in many instances. And that's what these evidence-based exercise programs really target. I did want to put in a plug really quickly for this trial that Dr. Kushan Patel is the principal investigator of, called the Pacific Study, which you probably have seen if you're around Harborview, have seen trifold brochures for. It's still recruiting, and it's actually looking at the combination of exercise and cognitive behavioral skills training for its effects on OA of the knee specifically. So people, if you have anybody in your practice who has active knee pain that's chronic, this might be something that you could point them to, and if they're interested, they could be screened for eligibility. So it's building out the already existing evidence base about the benefits of exercise alone, and looking to see whether another modality, when combined with exercise, is more effective than the comparator, which is the cognitive behavioral training alone. So in summary, how are we going to address this challenge? Just to think through this a little bit. The message is pretty clear here. We really need to increase providers' awareness and focus on the risks of medications in their care of older adults, in their daily practice. There's also a huge opportunity to try to increase awareness among older adults and their care partners about these risks, of course. And our trial, the Stop Falls trial, is trying to target both patients and providers. And so there is certainly a lot more to come, looking at whether or not this actually changes longer term clinical outcomes that are relevant to patients. But we know from those earlier studies that I shared with you that some of these interventions, such as provider decision support tools and decision aids for patients, have been effective in at least reducing the use of some of these sedative hypnotics, and yet really there are no trials at this point looking at other classes of medications that increase fall risks, such as the ones that I've shown you here. So a lot of research still to be done about trying to add to that evidence-based around the highest quality evidence, trial evidence. And lastly, I think really trying to focus on how can we manage these symptoms without medications. There are, with our coming generations of older adults and people who will be maybe a bit more amenable to using digital resources, there are digital resources that are going to be available for people who are receptive to them. There already are, for example, CBT apps for insomnia that are self-guided and evidence-driven. So trying to point people to those will be increasingly important. So that's it. Quick walkthrough of what data there is, and hopefully this was helpful.
Thanks so much. We have time for questions. There were some comments in the chat about the coverage of mirabegron. We had a side conversation about it. It seems like some folks have had more success than others in getting insurance to cover it. I don't know if you had any additional comments on that.
Can you put up the URL again? I'm not that fast.
The evaluation is also in the chat. Diane pasted it in there if you're able to click on that link. And I can paste it again.
Yes, not all older adults have Part D, of course, but those who do. That's a good point, Kate, that it is covered. And as Kate points out, it's available in the VA system as well. So it really is dependent on where people practice, I would say at this point. I didn't go into a lot of detail about the specific exercise programs as part of this talk today, but certainly, you know, there are a number of them. I chose not to list them, but there's a number of them. And I guess the other point to make while people are thinking of other questions is, we know that Tai Chi is probably the most effective form of exercise for fall risk reduction. And the fact that it also works for these other symptoms, I think is really important, because people get multiple benefits from doing a single thing. And most of the people, if not all the people that we see, you know, we may see a selected group, of course, but they often come back and say how much they really enjoy it. And another research study I was involved with Karen Sherman over at Kaiser a number of years ago, looking at Tai Chi for back pain, showed all sorts of, in that study, all sorts of benefits beyond just back pain control, improve sleep, improve mood, improve quality of life. So and it's actually fairly available through YMCAs, senior centers. So it's not as hard to find as some of these other programs that the NCOA endorses.
That's great. And Kay mentioned that Tai Chi is available in their fall prevention and balance class at the VA. So that's great. The VA has so many great resources. Lisa is asking if there are any studies that compare the risks from different classes of drugs used to treat pain.
That's a good question. Specific to fall risk, I did not find any. Yeah, most of the comparative studies have looked at as I mentioned, the various classes of antidepressants. And there's been more work, I would say, on sedative hypnotics and other drugs than there have been with pain medications.
Carrie, I think, had an additional question related to Mare background. I don't know, Carrie, if you wanted to unmute or I can read it.
Yeah, sure. Amy had asked about side effects of that. And so also sort of benefits, right? Like, do we have data that shows that this is helpful? Because I also am still seeing a lot of anticholinergics for this reason, and people are hesitant to stop even if they only think it's helping a little. But you know, if you're going to go through down the pathway of like cost and switching and all of that, do we think it works?
I don't know
have data?
If other people want to answer that from practice experience.
And then I'll also say that
I haven't seen enough people on it, and I didn't actually look at that question, but it's a great question.
I'll say that I think a lot of there's a little bit more use in the GYN Eurogyne world on vaginal estrogen for this, even for the irritability piece as well. So just another thing to keep in mind. But yeah, it's hard to like try to get people to switch to a drug when you don't have like a lot of experience that it really helps. Yeah, Amy's saying she's not been impressed. Yeah, that's kind of been my experience too.
Yeah, and I think some of the physiology of overactive bladder is going to be hard for any drug to actually counteract. The involuntary contractions of bladder associated with aging. So my sense is that it's probably not necessarily more effective, and that all these drugs are going to have modest benefits. And certainly, again, first line therapy for for bladder symptoms is not medications, building off of the idea of non-pharmacologic management. Amy's asking if other people have seen tachycardia associated with use of mirabegron.
Yeah, I have not seen a lot. I've used quite a bit of mirabegron, and I think as far as efficacy in trials, it's really similar to the anticholinergics, and I like it because of I have plenty of patients with cognitive impairment or other reasons that they can't easily take an anticholinergic. Plus, I just don't like anticholinergics. It makes my hand shake to write a prescription for an anticholinergic as a geriatrician. Although sometimes it's needed. But I haven't seen a lot of tachycardia. I have seen a little bit of hypertension more commonly. So just have to watch for that. But to answer your question, Amy, at least from my experience, I haven't seen a lot, but it would be interesting to hear others have had different experiences. And I've used it in, multiple patients who have AFib and haven't seen any issues with it.
Evidence for, so Kay mentioned that the off-label use with little evidence of gabapentin. Yeah, that actually was, you always learn something when you're preparing talks. The other thing I learned that I didn't mention is Trazodone is actually indicated for short-term use only for the off-label use of insomnia. And I don't think that was something I was never aware of. So again, to put that out there, even similar to benzos, these drugs often get continued indefinitely. And I think, again, behooves us to keep looking at people's regimens and be sure to ask about over-the-counters that they're taking on their own in addition. Barb's question about chair yoga for pain and overall balance. Kind of our mantra with balance is that you have to be standing to improve your balance. So, chair yoga, I don't know that it's been studied for pain, but certainly from the standpoint of balance, it's not an exercise that we would recommend.
Thank you. I know we always say that. I just wondered if there was anything, I sort of tried to put it in there. If just the increased body awareness, learning to breathe better. I just wonder. I have no evidence. I just was thinking about having seen a chair yoga class one time, and it did seem to make people sit up more erectly, etc. So,
well, it's actually really common for older people to do chair as opposed to yoga, standing or on the floor. So, I guess the one benefit for that, to your point, would be that it could increase core strength, which is important for prevention. Kay has her hand up. I don't know if you've looked at on chair yoga at all.
Yeah, I don't think there's any good evidence that I'm aware of, but I would say clinically and practically, that's how, the physical therapists that I work with would probably utilize something like that, right? If they are, and that's kind of the MO of GeroFit, right? So our GeroFit program, which I also didn't put into the chat at the VA, it has levels. And so sometimes it might be, is this person really high risk and a high safety risk? And if that's the case, at least they're doing something. It might not necessarily get to the point of evidence-based fall prevention, but it might be the first step to getting them to do anything. Yeah, but as far as how that will, amount to fall prevention and or reduction and, other sorts of important outcomes, hard to say.
I did just sort of have the thought occur to me as Kay, you were talking about it, that there is now a seated version of Tai Chi that Fuzhong Li, who developed Tai Chi Guan for specifically a simplified version of Tai Chi for fall prevention, has been working on. So our physical therapist in Falls Clinic is working with patients who are, as Kay says, very high fall risk, who, we see people who can't stand up from a chair all the time. And so starting with them in the seated Tai Chi, so they're actually using their core, because they're moving their upper body as part of that chair-based Tai Chi. And so I think there will be, I don't know as there's publications on Fuzhong's chair-based Tai Chi, but we can watch for that.
Sorry, I was going to jump in one really fast thing to point out that I think was actually maybe hidden in your presentation of Kushang's study, is that I saw that it's a virtual study. And I think one of the things too to point out is that virtual exercise programs might be just as efficacious as in-person, let alone virtual programs for specifically balance training, which might seem counterintuitive, but there's more literature coming out that is such the case. And that we have personally found that is a much more preferable, as long as the person, I almost said veteran, but as long as the person can get on to, a virtual platform and has support and skills around that, that is actually a preferred method. So I just wanted to throw that out there too.
Yeah, actually, I don't know if the paper's been published yet, but Kushang has a small pilot study that, trying to think, has it been published or accepted? But anyway, to support that, that finding, Kay, that the virtual actually did achieve, well, this study actually looks at achievement of, it's a kind of a preliminary look at some of the, like a pilot study that was done that used a virtual format and looked at the level of physical activity using heart rate monitoring, and found that people achieved the desired level of exertion for a sustained period of time. I think it was like 20 minutes. So there'll be more to come out of his studies looking at some of these other outcomes that we're talking about.
Great. Well, I think we're very close to 9 o'clock, so we'll probably wrap up now. Thank you so much for this talk and for answering all of our questions. And thanks everyone for engaging in a great discussion.
Have a great day, everybody.